please. Yes, ma'am, I've allowed it.
Thank you.
એક જ જણ રે બાકીના બધાને જોઈ લેજો કારણ કે મારે આપણું જોઈન હોય છે બી પેશન્ટ
ડિકોમ્પ્રેસિવ પેનેક્ટોમી થઈ ગઈ અને પેલું વેન્ટ્રિકલ ડ્રેનેજ કરી દીધું
all right, fine.
M2, M1 changes, P2P unequal non-reactive, sluggish. Current status looks even with M1, pupil unequal sluggish reactive and patient is in bad situation currently. I told him to give
even V1 M1.
even VT M1 and unequal sluggish reactive. I told him to give MPS, so he was thinking that is there any role of MPS?
No, GCS we
can only for trial basis.
They don't know that build it. समझाएं मोकली जाए.
Now, Gopi sir, can you unshare your screen?
Hello.
Yeah, Gopi sir, can you unshare your screen, please, sir?
Shall I?
Dr. Gopi, stop screen sharing.
Sir, you can share screen.
Okay.
તમારે બધાએ લોકોને જરૂર નથી ભાઈ.
Shall we start?
So, yeah, so can we start? Lakshmi sir, Sudhir sir? Sir, I think we can start. If the attendance were joined by the time we initiate the case discussion.
Sir, shall we start?
Yeah. Yes, please. श्रद्धा जी चालू कर दो.
Okay, sir. Good evening, everyone. Hello, everyone. And today we are at the New Year Eve. We are going to celebrate the New Year, and we are going to welcome the year 2023. Just a day ahead. And I welcome you all for this Secret of Neurology, which is the longest web series till date in the medical profession. And we are very thankful to our course director, Dr. Sudhir Shah sir and Dr. Narasimhan sir, those who have designed this web series in such a fantastic way. Today, we welcome the Andhra Medical College team, those who are going to discuss today's case study, and the session will end by 9:30. So, not wasting much of time, I'll just give a brief introduction of our course director, Dr. Sudhir Shah sir. He is a professor and head of department, NHL, MMC, and SVP IMSR, Ahmedabad, and Director of Neurosciences, Sterling Hospitals, Ahmedabad. Sir is having a great interest in stroke and neurodegenerative diseases and epilepsy. So we are very much proud to say that he is the recipient of prestigious Padam Shri Award in 2016. And our second course director, Dr. Lakshmi Narasimhan sir. Sir, he is a director and professor of Institute of Neurology, Madras Medical College, Chennai. Sir is a great academician and he is a 3 times executive member in the Indian Academy of Neurology and CME convener and Indian Academy of Neurology, and successfully organized a 7 consecutive clinical neurosciences program for the postgraduate students. So welcome you all, sir, and welcome to Dr. Sudhir Shah sir, and welcome to Dr. Lakshmi Narasimhan sir. Nothing to waste my time. I am handed over this session to Dr. Sudhir Shah sir. Sir, over to you.
Thank you. Thank you very much, Mr. Shraddha, for those kind words of introduction. First of all, I thank all the delegates for giving continuous support, enhancement, appreciation, and participation all throughout this 29 episode. And that is the reason why we are entering today in 3038th episode. I must also wish you all a wonderful, happy new year, prosperous and healthy new year, and a wonderful corona-free new year. Although we know that corona is hanging around, but I wish and we feel that it would be a very mild stroke, and the masks are back again. So take all precautions and take care of yourselves, please. Well, we wish and pray that this 2023 would bring lots of good news for us and no coronas, please. I also want to thank all the previous participant colleges and their faculties who have contributed immensely. Frankly speaking, through this series, we as course directors are also learning certain things which we would have otherwise missed in our busy practice. But thanks to this continuous medical education. On a very humble note, I may say that although this maybe you may take pride of this being the longest series, etc., but frankly, it is because of you all, which is a basic motivational force behind this continuous efforts. And I must say that more work is done by my colleague, Professor Dr. Lakshmi Narasimhan than me. I must confess that he is a very hard, sincere worker, and I have never seen such a wonderful human being. So I want to thank him at the end of this year 2022 once again. And not the least, I would appreciate the efforts of INTAS Global Cell Division led by Mr. Chadda and his team, Dr. Haley and others, Manoj Kumar, Doctor, and all, for their active involvement and support for the infrastructures and all those logistics. I hereby invite today's medical college, Andhra Medical College, that is based in Visakhapatnam, and the case discussion is the senior resident, Dr. G. Josna from the Department of Neurology, Andhra Medical College, Visakhapatnam. I think this is the second turn then they are presenting case, so we really appreciate this college. Dr. Bushu Rajan was last time, he had presented, his colleagues had presented another case. Dr. Sushma today will take this case forward with some dissection, and that is, she is Assistant Professor, Department of Neurology, same on the Medical College. Then Dr. Satish Kumar, who is the Associate Professor from Andhra Medical College, Department of Neurology, he would have investigations and differential diagnosis from this case. And most important, Dr. S. Gopi, my friend, who's a professor and HOD. I must compliment and congratulate him for being elevated to the post of HOD recently from the same medical college. And as you know, the case is progressive extrapyramidal disorder. So it's a guess for all of us right now, but I'm sure Dr. Gopi and his team would bring out something very interesting and something most learning for all of us. He had lots of awards and accolades. He was awarded gold medal in ophthalmology in MBBS and got national level first prize in essay writing in tuberculosis and got first prize in national level quiz at API. He was jury member for TISA for the journal round. He was also faculty at Shine and IN, Econ, and several other conferences we meet and have wonderful opportunity of listening to his very crisp talks. He's a member of various organizations, including IN, IS, etc. Activity member of APNSA, ex-secretary of Ethics Committee, Andhra Medical College, etc. He has 15 original articles in index journals and is presented paper in World Congress Neurology, Bangkok 2009 on variants of GB syndrome. So once again, friends, welcome again for this 30th episode. Thanks to all of you and wish you a wonderful time ahead. Take care of yourselves. Over to you, Andhra Medical College.
Yes. Good evening, everybody, respected panelists. I'm Dr. Jyotsna Pavni, final year neurology resident from Andhra Medical College. Under the guidance of Gopi sir, I want to present a case of a 25-year-old man, a lift cleaner by occupation, hailing from Gopinathpur, Orissa, who studied up to 12th standard, presented with chief complaints of speech disturbances since the last 3 years, involuntary movements since 1 year, and behavioral disturbance since 1 year. History of present illness. The speech disturbances started as slurring of speech with straining while speaking, producing low volume of speech, and it used to be unintelligible for the family members, and he used to communicate with gestures. And these speech disturbances are progressive in nature, and these speech disturbances are not associated with any nasal twang or undue stress over the syllables or mumbling, and it is not associated with difficulty swallowing, choking, or nasal regurgitation of reeds. Since the last 1 year, there's a history of involuntary movements affecting all the 4 extremities. These involuntary movements are sudden, random, and irregular and purposeless movements affecting both the hands and feet. It started as fidgetiness, which gradually progressed along with piano key-like movements at the fingers and toes. And these involuntary movements are not suppressible by the patient, and they aggravate while talking and walking, and they totally disappear during sleep. Since the last 1 year, there's also a history of abnormal posturing of both the hands. The father says that his son puts his fingers straightened with the thumb approximated with the other fingers, and there is no history of diurnal variation in this posturing of hands. There is no history of slowness of activity, tremulousness in limbs, or postural instability. There is no history of involuntary movements of the tongue, trunk, face, tongue, or any involuntary vocalization. And there is no history of abnormal jerks of the body. Since the last 1 year, our father also reports history of behavioral disturbances. There's a history of excessive irritability, anger outbursts, and at the peak of the anger, the patient hits the family members. And there's a history of excessive wandering behavior, both present during both day and night. There is no history suggestive of any hallucinations, delusions. There is no history of suicidal ideation. There's a history of excessive eating present. And according to the father, there's a history of fixed smiling stare, along with inappropriate social behavior. But there is no history of any hypersexuality, hyperorality. There is no history of inappropriate urination or defecation. There is no history of reduced social interaction or lack of motivation. There is no history of memory disturbances. Since the last 1 year, there's also history of unsteadiness of gait present while walking, which is in all the directions, but not to the extent of falls. And there is no history of any exaggeration of unsteadiness with the eyes closed. There is no associated tremulousness while reaching for objects or undue stress over the syllables or shaking of the body while sitting on the couch or to and fro motion of the head. There is no history of difficulty getting up from squatting position. There is no history of difficulty getting upstairs. There is no history of difficulty gripping chappals. There is no history of difficulty holding objects with either hand. No history of difficulty elevating limbs above the shoulder. There is no history of stiffness in limbs or jerkiness while placing feet on ground. There is no history of diminution in vision, double vision, or drooping of eyelids. There is no history of loss of facial perception, difficulty chewing, difficulty closing eyes, or deviation of angle of mouth. There is no history of difficulty swallowing, no history of difficulty shrugging shoulders or manipulating a food bolus. There is no history of tingling, numbness, or pain. There is no history of bladder or bowel disturbances or any abnormal sweating. There is no history of seizures. There is no history of headache or projectile vomitings. There is no history of oral ulcers, joint pains, or photosensitivity. There is no history of genital ulcers. There is no history of dry eye, dry mouth. There is no history of yellowish discoloration of eyes. There is no history of abnormal sleep behavior. There is no history of drug or toxin exposure. There is no history of cough, weight loss, or night sweats. There is no history of self-mutilation behavior. There is no history of excessive fatigue or tiredness. There is no history of blood in the urine or loin pain. There is no history of breathlessness, palpitations, or swelling of feet. Past history, there is no history of HIE during birth. There is no history of developmental delay. There is no history of hypertension, diabetes, or seizure disorder. There is no history of psychiatric illness in the past. There is no history of jaundice or chronic liver diseases. Personal history, there are no addictions. Patient takes balanced diet and sleep is normal, but the appetite is increased. Family history is a product of non-consanguineous marriage. He is second in birth order, and his mother died at an age of 45 years with a heart attack. And there's a history of dystonic posturing of both the hands in the mother. Summarizing my history, a 25-year-old man presented with 3 years duration of chronic progressive chorioethitosis affecting all the 4 limbs, along with focal hand dystonia and dysarthria, along with behavioral disinhibition and emotional incontinence and mild gait instability, with no history of seizures, myoclonus, autonomic, or sensory involvement. Localization, the generalized chorioethitosis and dystonia and dysarthria, probably the bilateral basal ganglia or its connections are involved. The behavioral disinhibition can be accounted by the affection of frontal subcortical circuits in the basal ganglia, and the gait instability, it could be because of the involuntary movement or because of the ataxia that could be localized to the cerebellum or its connections. My first possibility from history is Wilson's disease. The points which favor Wilson's disease are the early age of onset and the progressive course of the disease, the presenting features of dystonia and chorea, along with behavioral abnormalities and ataxia, and a positive family history. But there are no gastrointestinal symptoms, no tremor, or no features of Parkinsonism by history. Next possibility is Huntington's disease. I considered Huntington's disease as the disease onset is in the 3rd decade and with a progressive course with features of chorea, dystonia, and behavioral abnormalities. But there are no features in the histories suggesting Parkinsonism or any cognitive impairment. My third possibility is neurodegeneration with brain iron accumulation. So one category, that is neuroferritinopathy, I want to consider because of the presence of chorea and dystonia and abnormal behavior. But neuroferritinopathy is usually present with onset in the 4th or 5th decade. And in this case, there is no, history-wise, there is no predominant oral, lingual or mandibular dyskinesias, and no features suggestive of Parkinsonism. I also considered aceruloplasminemia for this movement disorder, but usually aceruloplasminemia will present in the 4th or 5th decade, and usually there's a preceding history of diabetes or anemia unresponsive to iron supplementation, and there is no history of visual complaints in the patient, no tremor or no oromandibular dystonia. The other NBIA I have considered is pantothenate kinase associated neurodegeneration. Again, the features not favoring the PKN are usually it presents in the first decade with a median age of onset of 3.5 years with a history of developmental delay, and history does not suggest any spasticity or visual symptoms. And PLA2G6 associated neurodegeneration I considered because of the presence of dystonia and emotional incontinence in the patient, but history is not suggestive of any spasticity or features of Parkinsonism. Again, chorioacanthocytosis is less likely because there is no predominant orobuccolingual chorea or feeding dystonia history-wise, and there is no history of any self-mutilation behavior. I considered one of the DD as dopamine responsive dystonia, as it is the dystonia is present in this patient, but chorea is rare in DRD, and there is no Parkinsonism, no features of Parkinsonism in this patient, and there is no history of diurnal variation in the dystonia. I also considered Friedreich's ataxia. The age of onset being less than 25 years with chorea, with ataxia, and rarely even chorea can be present in Friedreich's ataxia, but there are no features in the history to suggest a peripheral neuropathy. There is no history of diabetes or skeletal deformities according to the history. I also considered SCA types 2 and 3 because of the presence of chorea and dystonia, but the absence of myoclonus or features of Parkinsonism, eye movement abnormalities in the history, absence of facial twitching, do not favor a diagnosis of SCA. SCA 17, which is a HT phenocopy, is also the favorable points for SCA 17 are dystonia, chorea, and ataxia, but there is no history of seizures, Parkinsonism, or pyramidal involvement history-wise. And primary familial brain calcification is also favorable, is considered in the diagnosis, but usually they present with symptoms of akinetic syndrome and tremor, which are absent in this patient. And I also considered mitochondrial cytopathies because of the chorioatherosis and dystonia, but there are no eye movement abnormalities history-wise, and there is no systemic involvement, either cardiac, hepatic, gastrointestinal, or renal symptoms. Niemann-Pick type C can have an adult onset movement disorder presentation, but history does not suggest any vertical gauge palsy. There are no features of Parkinsonism or dementia in this patient. So shall I go ahead? General examination. The patient is conscious, alert, and cooperative. Height is 185 centimeter, weight is 76 kg, BMI is 22.2. His blink rate is increased, it is 30 per minute, and there are no signs of liver cell failure. There is a patient has a characteristic faces with an open mouth and fixed vacuous smile, and sometimes drooling of saliva. There are no tongue or lip bites. There is a pigmented dry skin present in both the lower limbs. And vital signs, his pulse rate is 75 per minute. It is regular, normal volume. Blood pressure is 120 by 80 millimeters mercury with no postural drop. and the respiratory rate is 16 per minute, and it is abdominothoracic, and temperature is 98.6 degree Fahrenheit. Cardiovascular system, first and second heart sounds are heard, and respiratory system, bilateral air entry is present with normal vesicular breath sounds. For abdomen is soft, no organomegaly. Nervous system examination, he's a right-handed individual. MMSE, he scored 26 out of 30. He lost points in 2 points in serial subtraction, 7 subtraction test, and 1 point in copying a diagram. He could not hold a pen, and he could not write a sentence. And physical observation, he was not unkempt, with elated mood. Language, fluency, comprehension, reading, repetition, and naming are normal. He could not write because of the involuntary movement. He could not hold a pen. Speech, there is a spastic dysarthria present. British Constitution was given for him to repeat. Lobar functions, insight. When I asked the patient why he has come to the hospital, he said his mind is not working, and judgment is preserved. When I asked what he would do on seeing a house on fire, he said he would call for help. Attention, digit repetition forward was 5, backward he could not count, and he could not tell the months backward. On sustained attention, random letter A test, there were errors of commission present. He could tell the dissimilarities, but he could not tell the similarities. And fund of information is good. And proverb interpretation, he could not do. And the category fluency, he could name 8 animals in 1 minute. And phonemic fluency, he only told 3 words starting with letter S. And visual and motor pattern completion test, both he could not perform. And Porteous maze test, he started the test, but he could not come out of the maze. Wisconsin card sorting test, he could sort the colors and numbers. And trail A, he could perform, but trail B, he could not shift responses between the alphabets and numbers. Tests of orbitofrontal cortex, go, no go is normal. Saccade, antisaccade, he could perform normally. Stroop test is normal, and applause sign is negative. Fab, he scored 10 out of 18. Recent memory, orientation to time and place are normal. Remote memory is normal. New learning ability, he could recall all the 4 unrelated words. He could recall verbal story, and visual memory was normal. But paired associate learning, despite 2 dictations, he could not tell the pairs. No ideomotor or ideational apraxia. There is no right to left confusion, no finger agnosia. He is able to do simple calculations. Clock drawing test, he could not perform because he could not hold the pen. There is no dressing apraxia, no geographic disorientation. There is no object agnosia, no prospagnosia, no color agnosia, and no simultagnosia. Cookie theft picture, he identified all the components of the picture. Cranial nerve examination, first nerve is normal. Second nerve, visual acuity is 6/6 in both the eyes. Visual fields are normal in both the eyes. Color vision is normal in both the eyes, and fundus is normal. 3, 4, 6 cranial nerves. There is no ocular malalignment. Position palpebral aperture is normal in both the eyes, and extraocular movements are normal and full, and saccades and pursuits are normal. No nystagmus. 5th nerve, sensations over the face is normal, and muscles of mastication are strong. 7th nerve, bilateral eye closure, orbicularis oris, all are strong. 8th nerve, normal. 9th, 10th, 11th, also normal. 12th nerve, the tongue bulk, power, normal, sir. There is no involuntary movement in the tongue and no impersistence on protrusion of the tongue. Motor system, normal attitude. Bulk is normal in both the all the 4 limbs. Tone, there is hypotonia at both the wrists, and in the lower limbs, the tone is normal. Power, it is normal in both upper limbs and lower limbs. And reflexes, superficial, corneal, conjunctival are present. Abdominals are absent on bilaterally, and plantaris flexor bilaterally. And deep tendon jerks, jaw jerk was present, and biceps, supinator, triceps, knee, ankle were 2+. No pathological and primitive reflexes. Involuntary movements, There were all involuntary, rapid, jerky, random, irregular, distal predominant movements. These were non-stereotypic at the hands mainly. Sometimes they were tapping in nature, sometimes rotatory movements. They were flowing from hands proximally into the shoulders, and sometimes these movements are semi-purposeful. These movements were accompanied by piano key-like writing movements at the fingers and toes. They were present while sitting, and they were exaggerated more while standing and walking. And there's a fixed facial smile present, suggestive of a facial dystonia. And there is a bilateral hand posturing present with extension at the metacarpophalangeal joint and flexion at the interphalangeal joints. On standing, there is exaggeration of the involuntary movements of chorea arthrosis. Cerebellar signs, there is no titubation, no nystagmus or scanning speech. In upper limb coordination tests, finger nose test, he is able to perform without, there is no intention tremor or dysmetria, but the chorea is interfering with the test. And he is unable to perform rapid alternating movements with both the hands. And there is no truncal stance or gait ataxia, but tandem gait he is unable to perform. Sensory system, fine touch, pain, joint sense, vibration sense are normal, and rhombox is negative. Tests of extrapyramidal system, finger tapping test, he could not perform the finger tapping test because of the abnormal movement interfering with the approximation of thumb with the index finger. Leg agility, he could perform normally. Pull test was negative. And signs of chorea, the hypotonia was present in both the wrists, and bilateral milkmaid grip was present. And there is no pendular reflex or darting tongue. Gait, patient is walking with a normal pace, but with reduced arm swing bilaterally, with the involuntary movement superimposed. There are no meningeal signs, and cranium and spine normal. And on general examination, there was a grayish brown ring in both the eyes, prominent in the superior and inferior aspects, suggestive of a KF ring. So, summarizing my examination findings, there is a bilateral KF ring present with a generalized chorioathetosis, facial dystonia, and bilateral focal hand dystonia with frontal executive dysfunction. My possibility at the end of examination is Wilson's disease. As it is associated with KF ring, which scores for 2 points, and presence of neurobehavioral symptoms which score 2 points. As the score is 4, a diagnosis of Wilson's is likely, sir. So shall I continue with the investigations?
Continue.
In this patient, the complete blood count, the HP, there was no anemia, sir, and there is no peripheral smear. There were no features of hemolysis or hemolysis. The liver function tests revealed slightly elevated AST level and with a normal ALT level, and the total bilirubin and direct were within normal limits. And the complete urine examination was normal. There was no hematuria or proteinuria. Ultrasound abdomen revealed the liver size of 15.6 centimeter with an altered echo texture, and the portal vein was normal in caliber with normal peak systolic velocities. The other pancreas, spleen, and kidneys were normal. And this was the slit lamp showing a grayish brown ring in the limbus bilaterally. This is the MRI scan, sir, which shows T2 hyperintensities at the bilateral lenticular nucleus, caudate, lateral and anterolateral thalamus, and in the pons. And the corresponding GRE does not show any mineral depositions. Patient's ceruloplasmin was 3.1 milligram per deciliter, and that which was markedly low. And 24-hour urine copper was greatly elevated, 558 microgram per day. Over. In a series of 307 patients from India, the commonest presenting symptoms were tremor, dysarthria, jaundice, abnormal gait, and chorea was reported very less to 0.3%. Whereas in some studies, chorea was reported to be 6 to 16%. This patient was started with D-penicillamine 250 mg per day. Thank you.
Okay. Sir, can we continue with Dr. Sushma, sir?
Sir, shall we continue or
Any discussion?
anybody want to discuss, sir? Hello.
Sir, you continue, please.
Okay, okay.
Yeah, you,
Dr. Sushma, you please continue.
Yes, sir. Josna, can you unshare your screen?
Yes.
Stop sharing. Was my screen visible?
Yeah.
Yeah,
Yes, yes.
Yes, ma'am.
Good evening, sir. Myself, Dr. Sushma, Assistant Professor in the Department of Neurology, Andhra Medical College. First, I would like to thank Dr. Gopi sir for giving me this opportunity to present in this forum. And I feel proud to say that I'm the student of Professor Dr. Lakshmi Narasimhan sir. It is a wonderful case presentation by Dr. Jyotsna, Senior Resident. Here we have discussed the case of 25-year-old male patient who presented with progressive neurological illness of around 3 years duration, who presented with dysarthria, involuntary movements, and behavioral disturbances, with examination findings showing the KF ring, frontal executive dysfunction with a TAP score of 10 out of 18, both chorioarthritic movements and dystonia of both hands, with gait instability, probably of cerebellar involvement, and the investigations in favor of Wilson's disease. I will be discussing on clinical features and differential diagnosis of Wilson's disease. Age at presentation. Wilson disease may present symptomatically at any age, though majority of patients presenting between 5 and 35 years of age. The youngest patient reported in the literature with cirrhosis of liver due to Wilson's disease was 3 years old. About 3% of patients usually present beyond the 4th decade of age, either with hepatic or neurological disorder. Here is a case report of a 3-year-old girl, that is youngest age group, presenting with severe hepatic Wilson disease, who presented with hemolytic anemia, hepatosplenomegaly, ascites, and decompensated chronic liver disease. And in this study, they have studied around 1,200 patients of Wilson's disease who presented of more than 40 years of age. And this is the oldest patient presented with Wilson's disease of 72-year-old woman and her sibling of 70-year-old man. Clinical features. Clinical features of Wilson's disease includes neurological manifestations, liver disease, psychiatric symptoms, and involvement of other systems. First, the neurological manifestations. Wilson's disease can present with an impressive spectrum of neurological, behavioral, or psychiatric disorder, which may be clinical first symptom and appearing simultaneously with hepatic signs or some years later. And this neurological presentation sometimes will be very subtle and stable for many years, but may also be rapidly progressive, leading to within a few months to complete disability. The characteristic tremor is a coarse, irregular, proximal tremulousness presenting with a wing beating appearance. And the dystonia can be focal, segmental, or very severe, involving all the parts of the body, leading to severe contractures. And the most common motor impairments involve the cranial region, manifesting clinically as dysarthria, which can be either cerebellar or extrapyramidal, and oropharyngeal dystonia. A fixed state with a patient with a smiling expression and drooling are characteristic features of the illness, but not seen in all the cases. Depending on the progression of the Wilson's disease, it can be classified into non-neurological form of progression, neurological form of progression, and psychiatric form of progression. In the non-neurological form of progression, it can be either preclinical, that is asymptomatic, mostly diagnosed prior to the onset of symptoms, especially in the first-degree relatives, or hepatic form of progression presenting with cirrhosis of liver and decompensated liver disease. In the neurological form of progression, it can present as pseudo-Parkinsonism type, pseudo-sclerotic type, or mixed form, that is arrhythmic hyperkinetic form. In the pseudo-Parkinsonism type, the predominant key clinical symptoms will be bradykinesia or hypokinesia, rigidity, tremor, minor resting tremor, dysarthria, and hypersalivation. In the pseudo-sclerotic form, that is tremulous form, the predominant clinical features will be postural or intentional tremor, cerebellar ataxia, and dysarthria. In the mixed form, there can be choreotic movement, athetotic movements, and torsion dystonia. The psychiatric symptoms. Behavioral and psychiatric symptoms are common and some of them may precede the neurologic or hepatic signs and symptoms. About 1/3 of patients initially present with psychiatric symptoms. In children, declining school performance, personality changes, impulsiveness, labile mood, and inappropriate behavior are observed. These initial clinical symptoms are frequently misdiagnosed as behavioral problems associated with puberty. In older patients, psychotic features resembling paranoia, schizophrenia, or depression can be observed, but sometimes behavioral changes are also seen. A delay in the diagnosis of Wilson's disease was seen in patients presenting with neuropsychiatric manifestations. And in the literature, reported case of around 12 years difference before the onset of symptoms and the clinical diagnosis. And presentation like liver disease. Any type of liver disease may be encountered in patients with Wilson's disease. Clinically evident liver disease may sometimes precede the neurological manifestations by around 10 years, and most patients with neurological symptoms have some degree of liver disease at the presentation. Presenting symptoms of liver disease can be highly variable, ranging from asymptomatic, which only detected by biochemical abnormalities, to overt cirrhosis of liver and all its complications. And Wilson's disease may also present with acute liver failure, sometimes associated with Coombs negative hemolytic anemia and acute renal failure. Other manifestations involving other systems include hemolytic anemia, renal abnormalities including aminoaciduria, nephrolithiasis, hypercalciuria, nephrocalcinosis, cardiomyopathy, and chondrocalcinosis or osteoarthritis, hypoparathyroidism, and pancreatitis. Moving on to the differential diagnosis, it can be divided into the following subheadings: differential diagnosis of extrapyramidal motor and cerebellar findings, differential diagnosis of the uterus, differential diagnosis of ATPases, that is defects in the cellular dysfunctions in copper metabolism, differential diagnosis of the KFE. First is differential diagnosis of the extrapyramidal and motor cerebellar findings. It includes differential diagnosis of cerebellar ataxia. It can be either Friedreich's ataxia, ataxia-telangiectasia, CJD, GSS, STAR2, 6 and 12, Niemann-Pick disease type C. And differential diagnosis for patients presenting with Parkinson's disease and tremors includes juvenile onset Parkinson's disease, that is PARK2 mutation, Parkinson plus syndrome, Kupffer-Jacob syndrome, PARK9 mutation, ALS Parkinsonism dementia complex, STAR3, Machado-Joseph disease, essential tremor, Westphal variant, PSP, and toxic. With the differential diagnosis of chorioarthroid hyperkinesias or dystonia includes neuroacanthocytosis, Huntington disease, focal and generalized dystonia, FAST disease, NDIA, Sigawa syndrome, medication and especially antipsychotics presenting with cardio dyskinesia and dystonia, psychogenic, which can either present as dystonia, tremor, or myoclonus, or any other movement disorder. Other differential diagnoses include Plateau G6 associated neurodegeneration. Here, the Plateau G6 related dystonia Parkinsonism presents with progressive spastic quadriparsis, Parkinsonism features, cognitive decline, and ataxia. Next is FAHN, that is fatty acid hydroxylase associated neurodegeneration, presenting with mixed movement disorders, optic atrophy, and spasticity. And Woodhouse-Sakati syndrome, presenting with hypogonadism, progressive dystonia, dysarthria, sensorineural hearing loss, alopecia, intellectual disability. Lewy syndrome, that is X-linked dystonia Parkinsonism, presenting with progressive dystonia, tremor, myoclonus, chorea, Parkinsonism, mitochondrial cytopathies, and hereditary hemochromatosis, presenting with dysarthria, ataxia, movement disorders, and Parkinsonism features. Next subheading is differential diagnosis of the uterus. It includes inflammatory liver diseases like hepatitis B, non-viral hepatitis, hepatobiliary excretion disorders presenting with cholestasis or conjugated hyperbilirubinemia syndromes, infantile metabolic disorders with uterus like cystic fibrosis, alpha-1 antitrypsin deficiency, etc. Differential diagnosis of ATPases. that is defects and cellular dysfunction in copper metabolism. This includes ATP7A mutations, that is Menkes disease. Presenting symptoms includes epileptic seizures, mental retardation, kinky brittle hair, microgynia, funnel chest, bladder diverticulum, muscular hypertonia, hypermobile joints. Next one is occipital horn syndrome. Presenting features includes calcification of the occipital bone, hypermobile joints, skeletal abnormalities, autonomic disorders. And third one is X-linked distal hereditary motor neuropathy, also known as ATP7A related distal motor neuropathy. Presenting symptoms includes loss of strength, distal muscular atrophy, peroneal nerve dysfunction, and axonal nerve lesions. And this Wilson's disease is ATP7B mutation, that is autosomal recessive. Genetics still uncertain or likely to be autosomal recessive includes Indian childhood cirrhosis and non-Indian childhood cirrhosis. Features include cirrhosis of liver, rapid progression of the hepatic insufficiency with no neurological symptoms, treated with D-penicillamine and fatal if not treated. Next is adaptinopathies, that is Mednick syndrome. Mednick stands for mental retardation, enteropathy, deafness, peripheral neuropathy, ichthyosis, and keratoderma. Treated with zinc sulfate, and liver disorder is treatable. Neurological deficits will be persistent. Other ATPase defects with extrapyramidal symptoms includes DYT12, which is autosomal dominant, presenting as rapid onset of dystonia and Parkinsonism. There is no treatment and quality of life is negatively affected. Second one is Cooper-Rackham syndrome, that is hereditary variant of Parkinson's disease with PARC9 mutation, autosomal recessive, presenting with symptoms of Parkinson's disease, eye movement disorder, pyramidal tract size, myoclonus, and mental retardation. Next is chaperone disorder, that is CCS deficiency, copper chaperone superoxide dismutase 1, presenting with developmental disorder, epilepsy, pericardial effusion, and hypotonia. It has no treatment. And the last one to consider in the differential diagnosis of the KF ring. KF ring is not specific for Wilson's disease. It can be seen in other conditions like primary biliary cholangitis, chronic cholestasis, in children with neonatal cholestasis, galactosialidosis, and cryptogenic cirrhosis. The KF rings are caused by the deposition of excess copper on the inner surface of the cornea and the Descemet's membrane. So, slit lamp examination is mandatory to make the diagnosis of KF ring, especially in the early stages, unless the KF ring are visible to the naked eye in conditions of severe copper overload. KF rings are seen in most patients with neurological involvement. Around 95% of the patients, they will have KF ring. However, it may not be seen in 5% of the patients. However, they are present in only 5% of the patients with isolated hepatic involvement and in the pre-symptomatic patients. Thank you.
So shall we continue next?
Yes. Sir, can I
Okay.
continue?
Okay, Satish, sir.
Okay. Sir, good evening, everybody, to all the panelists. I sincerely thanks Dr. Lakshmi Narasimhan and our HOD for giving this opportunity to present in this forum. So that was an extensive clinical discussion regarding the clinical features and the differential diagnosis by Dr. Sushma, and a wonderful presentation of the case by the Dr. Jyotsna, our senior resident. So why we have taken up this case is, although it is a commonest disease we routinely encounter, the presentation with chorea is less common, as routinely we don't see. Usually Parkinsonism presentation and some association with some association like frontotemporal component. These two things are routinely we don't see. So that's why we have taken up this case. Otherwise, it's a routine case we routinely see. So coming to our discussion regarding this, so 1 second. So
Sir.
it's, sir,
Sir,
yeah,
sorry to disturb you. Can you go with the full screen?
yeah. So, sir, now it's okay. Okay.
Thank you, sir. Thank
Right.
you. Yes, sir.
So it's already it has discussed by Dr. Sushma. The autosomal cellular defect in cellular copper transport, especially introduction of the copper into the ceruloplasmin because of the ATPase deficiency. So it is approximately the epidemiology is regarding 1 case in 1,000 live births in most population worldwide, and almost similar in India also. Impaired biliary copper excretion is the basic thing, because of which accumulation of copper in several organs, most notably in the liver, brain, cornea, and other organs, as Dr. Sushma discussed, like parathyroid and pancreas. So any patient, especially young fellow who is presenting with unexplained liver neurological psychiatric abnormalities, we have to think in lines of first possibility, because as it is a potentially treatable condition, and early detection and treatment may prevent the disease further and even reverse the symptoms in some patients. So as it is because as we other heredodegenerative disorders, it is a potentially treatable disease. Hence, early diagnosis is very much important and crucial because of potentially treatable condition. So regarding the how do you go with the diagnostic diagnostic test? So routine test will do like here in this the complete hemogram is normal, but we have to suspect, because that is also affects the hematological disorders like aplastic anemia. So complete blood picture, liver biochemical test to look for any silent liver abnormalities, and serum ceruloplasmin levels and serum copper levels, 24-hour urinary copper excretion. So these are the routine first tier of investigations we do if you have clinically strong KF on examination and general examination, or OCT or slit lamp examination. So if these tests are indeterminate, if we require an additional testing like liver biopsy with copper quantification, which is an gold standard test in diagnosing of Wilson's disease, and histological evaluation. This is and histological along with molecular testing for ATP7B mutations, which is routinely not necessary, but especially in screening the siblings or asymptomatic heterozygote individuals. So this is as Dr. Jyotsna has already given. So this is a scoring system, out of which, if suppose 4 or more score is diagnosis established, here we have more than 4. KF ring is present, neurological symptoms are mild, and serum ceruloplasmin level is significantly reduced. That is less than 0.3 grams per liter. And these investigation reports have shown the Lipsky score is 4 or more, hence the diagnosis was established. So this is the histopathology of the liver involved individuals of Wilson's disease. So left panel showing the infiltrations, lipid accumulation, and the right panel shows the fatty infiltration of the hepatocytes with the glycogen nuclei, two glycogen nucleus mass and trichrome technique. So regarding the ceruloplasmin, which is a crucial here, and we have got positive here. So it's a protein which is necessary for the insertion of copper into the protein, and so that the copper does not spill over into the circulation, and further prevention of deposition in the various organs. So low serum ceruloplasmin level, that is less than 20 milligrams deciliter, is almost present in more than 90% of the individuals with Wilson's disease. So these are two forms of serum ceruloplasmin in the blood, but we found the whole ceruloplasmin is the one we have to test by various techniques, because epoceruloplasmin, which is unbound form, which is unstable and easily excreted to the kidney and may not be, it's not usually tested. So most of the amount of the ceruloplasmin which is present in the serum is a holoceruloplasmin, which is copper bound. And so there is impaired hepatic incorporation of copper into the epoceruloplasmin, so that the copper will be spilled out into the blood or serum. So there are, while interpretation of the serum ceruloplasmin level, so serum ceruloplasmin need not always be low. Sometimes it may be high or normal level also. We have to see certain associated conditions and any drug intake, or the patient is pregnant. So in these conditions, usually ceruloplasmin levels normally also rises. So we have to clinically we have to interpret if any other condition like inflammatory states, hormonal supplementation, especially in the females in pregnancy, and elevated in pregnancy. So these things we have to check before giving importance to the serum ceruloplasmin levels. So low ceruloplasmin levels are also seen in other conditions like asymptomatic heterozygous carriers, disorders with marked enteric or renal protein loss like nephrotic syndrome, which is also a complication of the penicillamine therapy, which is usually given in the Wilson's disease, end-stage liver disease, Menkes disease, copper deficiency, aceruloplasminemia. And the method which we will test the ceruloplasmin level is also important. The commonest test we routinely the testing method is enzymatic method. So this is the best method because it doesn't overestimate. If you test by antibody dependent assay or radioimmunodiffusion methods, they test both holoceruloplasmin and epoceruloplasmin levels. So hence it is there will be a overestimation of the ceruloplasmin if we test these methods. And regarding the serum copper, it is reduced in proportion to the serum ceruloplasmin. So we have to compare with serum ceruloplasmin, the serum. If there is a marked elevation in acute liver failure with Wilson's disease, it tests both bound as well as unbound form with ceruloplasmin. And if the non-bound ceruloplasmin found is elevated, then it is a diagnostic test for Wilson disease. Especially this is used for therapeutic monitoring while giving the deep penicillamine therapy, whether the levels of the serum copper comes down over a period of time, especially when to give a maintenance dose, when to taper the dose, we can check with serum copper levels. But most important thing here, it is a urinary copper excretion. It is used for both as well as a diagnostic test as well as for the monitoring therapy. So it is normal urinary 24 hours excretion is usually less than 40 micrograms per 24 hours. In case of Wilson's disease, usually it is more than 100 micrograms over a period of 25 hours. So other conditions where there is increased urinary copper excretion is chronic active hepatitis and heterozygous for Wilson's disease. But the amount of urinary copper excretion is usually between 40 to 100 micrograms in these conditions. So if the patient is having associated Wilson's disease or not, we have to give a penicillamine challenge by giving 500 milligrams of D-penicillamine at the start of collection. That is, initially we have to discard the first urine when we get up from the bed and start collecting from the second urine sample. So you give 500 milligrams and after 12 hours, and we have to collect the urine from the next day, that is at 6 a.m. The sample from getting up from the bed. Till that time, we have to collect and give and look for the urinary 24-hour copper excretion. So usually urinary copper excretion with penicillamine challenge by 500 mg twice daily, usually 69 micrograms. Here is also positive in our case. So these are the routine blood investigations, which are physiological changes and other things in Wilson's disease, which are almost the investigations we have done positive in our case. And whereas coming to the neuroimaging findings, these are not specific. If they are not present also, we can't give importance to them. But here it is in the bilateral basal ganglionic region. But typical neuroimaging findings in Wilson's disease are face of giant panda because of the hyperintensity in the tegmentum and intact rubral red nucleus, or hyperintensity in the hyperintensity in the bilateral basal ganglia and posterior limb of internal capsule as well as the thalami, which are the other differential diagnosis for mitochondrial disorders. And the trident sign, this is another finding which is not so much common in Wilson's disease. And face of giant panda and face of miniature panda, especially their hyperintensity, because hypointensity of the central tegmental tracts, it looks like a miniature face of the miniature panda. If both giant panda sign as well as the miniature panda sign is seen, then it is known as face of double panda sign. But these are not, these are also, although they are typical, not in most of the conditions. So additional testing. So what the basic investigations we do, they are positive with low ceruloplasmin level, KF-free, and extrapyramidal syndrome. These additional testing is not necessary unless there are some physiological changes associated. If there are low false positives testing in the serum ceruloplasmin levels, or the Leipzig score is less than or equal to 3, then additional testing is necessary. The additional testing goes like liver biopsy. The dry weight of the liver has to be how much copper in the dry weight of liver. In the liver biopsy, if it is more than 250 micrograms per gram of dry weight of liver, it's a gold standard test, which is seen in Wilson's disease. And the histology, as I already discussed, it will be fatty infiltration of within the hepatocytes or glycogen inclusions within the nuclei and portal fibrosis. And the genetic testing is not routinely necessary unless there is 100% findings. But if they want to screen the asymptomatic siblings of the patients, then ATP7B mutations can be tested by genetic mutation. So regarding the management, so the best method to follow is the American Association of Study Group of Liver Diseases. The treatment goes like this. So treatment in the goes in two steps. So one step is, first we have to tell that the treatment is lifelong. It should not be withdrawn, but the main problem is non-compliance. Because of lifelong treatment, the non-compliance is a major thing in Wilson's disease patients, and the associated side effects with the first line drugs like D-penicillamine. So, but anywhere, if there are no side effects and the compliance is good, there will be a reversal of the symptoms also. So there are two phases in treatment. First phase is removal or detoxifying the tissue copper, and so that the main reversion of the already existing neurological symptoms occurs. So after this stage, and once that this detoxifying stage is over, we have to maintain that treatment with preventing reaccumulation of the copper into the tissues by chelators or zinc salts. So the maintenance dose should be 33% of that are used for detoxifying doses. The potent chelators which we use is the most common drug is D-penicillamine, which is a potent chelator of the tissue copper. And the second drug is trientine and the tetrathiomolybdate. This trientine and tetrathiomolybdate is not freely available in India. And zinc salts, which increase the level, zinc salts is a copper chelator, but it is indirectly increases the levels of methathionin, especially in the GIT. So also in the liver. So as by increasing this metallothionein, which is a chelator, so that decreases the absorption of the copper and luminal excretion of the copper in the first step itself, it increases. But zinc salts as the first line of therapy is not that much useful unless there is a side effects regarding the depends on the patient cannot tolerate the D-penicillamine, then we can go with the zinc salts. The combination therapy with chelators and the zinc salts are not that much, studies have shown not that much results. So we have to try with the first step. So this is the protocol. So initial treatment for symptomatic patients should be a chelating agent, that is diethylmethylamine or trientine or tetrathione but trientine is better tolerated than tetrathione molybdate, but it is not freely available. So at the same time, we should avoid taking the foods and water with high concentrations of copper and the treatment of pre-symptomatic patients or maintenance therapy can be accomplished with its chelating agent. Once the acute phase is, next is the maintenance phase. Suppose if the patient has acute liver failure due to Wilson's disease, patient with acute liver failure due to Wilson's disease should be referred for and treated with liver transplantation at an early stage. Patient with decompensated cirrhosis unresponsive to the chelation therapy should also be evaluated and promptly should be sent to the liver transplantation at the earliest stages, so that the neurological complications doesn't set in. And treatment for Wilson's disease should be continued even during pregnancy, because the only we can reduce the dose to 25 to 50% of the non-pregnant levels, but it can be continued. Treatment is lifelong and should not be discontinued unless a liver transplant has been performed. Liver transplant is curative. But liver transplantation for neurological symptoms, the studies have shown that much improved. If the patient purely only present with neurological symptoms of Wilson's, liver transplantation have shown not that much results, because liver transplantation also after transplantation also the treatment has to be continued. The side effects of deep encellular increase. So but in case of hepatic Wilson's, it is an excellent treatment and permanent treatment. So monitoring of the treatment is done by 24-hour urine copper excretion while on medication, should be measured yearly and more frequently if there are questions like compliance or if doses of medication is adjusted. The estimated serum north-central copper may be elevated in situations of non-adherence and extremely low in situations of over-treatment. So regarding the D-penicillamine, it is the sulfhydryl group of the D-penicillamine is the one which is had a copper chelating moiety, so that it removes the tissue copper. So starting dose is 250 to 500 milligrams per day, escalated at the dose of 250 milligrams per 4 to 7 days. The immediate reaction usually comes by starting is in some patients as early reaction, that is fever, cutaneous eruption, lymphadenopathy, neutropenia, thrombocytopenia, and proteinuria. So usually develop within the first week. So if the patient develop any of these, we have to stop the drug immediately and we can give the steroids. And if you want to restart, if there is other drugs are not available like trientine, we can start with again after a few weeks when all the symptoms are subsided and blood counts reaches normal level. We start with 25 milligrams per day and escalate double the dose every weekly till the patient gets tolerated. So in case of acute reactions, we have to start with 25 milligrams and gradually escalate, doubling the dose every week till the patient can tolerate. But normally if the patient is tolerated, then we can increase the dose up to maximum of 1000 to 1500 milligrams per day in 2 to 3 divided doses. Because D-penicillamine is one which if you give orally, the food especially impairs the absorption of the D-penicillamine. So 50% of the dose will be lost. And so better to give penicillamine 1 hour before or 2 hours after the food. Then regarding the children, if less than 45 kg, 250 milligrams per day or 20 mg per kg is the usual dose, and maintenance dose usually between 750 to 1000 milligrams per day. The late side effects. So during monitoring also we have to check for this urine protein examination, complete blood picture every week, twice weekly for up to 3 months. After that, every monthly for the 6 months, and then every 6 months if the patient is tolerating. So regarding the nephrotic syndrome, crysantic glomerulonephritis, Goodpasture syndrome, bone marrow toxicity, myasthenia gravis, polymyositis, liver toxicity, leukocytic syndrome, and pyridoxine deficiency will occur if you give D-penicillamine. Hence, pyridoxine supplementation at 25 milligrams per day usually should be given along with the D-penicillamine. And the maintenance dose, the monitoring of the treatment responsiveness usually by monitoring the urinary copper excretion. Usually if the urinary copper excretion increases by around 100 micrograms per day after from the baseline levels, before the starting treatment, then that's a good response regarding the treatment of, that's a good response with dipencylamine. So other drugs like Trientine, we can give at the dose of 20 milligrams per kg per day in 2 to 3 divided doses. It can be given as a primary drug if available, or if their patient is intolerant to or side effects with dipencylamine. And zinc, it increases the level of, as I have showed, increase the levels of metathionine, which is in the liver as well as the GAT, which clears the luminal copper. So it's arrests the copper absorption at the first level. Zinc acetate is the best form because it is a which is a good luminal zinc acetate form is better form than zinc gluconate and zinc sulfate because it has a better absorption. And the dose should be calculated in the form of a elemental form, like zinc, elemental zinc in the 150 mg 2 to 3, not in the salt form. So 150 milligrams 2 to 3 divided doses. If the children for less than 45 kg, 75 milligrams per day. So ammonium tetrathiamolybdate, it works both luminal as well as a plasma copper. It is also a chelator. Dimercaprone, initially it was used, but because of the local sterile abscesses weekly injections of 2 to 3 ml, so it is patient non-compliant and local sterile abscess, it is not given routinely. And when do you stitch to the maintenance therapy? If the patient is clinically well, stable, near normal serum aminotransferase levels and hepatic synthetic function. Normal serum normal plasma count should be at least less than 150 micrograms per liter. And 24-hour urinary copper levels should reach 200 to 500 micrograms over a period of 20 years. Mostly the treatment to switching, the patient is significant neurological and the patient is tolerant. Usually it reaches after 6 months to 1 year. So that is regarding the treatment, sir. So Dr. Gopi can continue.
Sir, Murali. Satish, unshare your screen.
Is it okay?
Okay,
sir.
Okay.
Right.
Share. Good evening, sir. Shall I continue, sir?
Sir, can you
Thank you.
do the full screen?
Full screen. Is it full screen only, sir?
Sir, it's not full screen. You just click him down.
Not get back from you guys. When should I follow up again? So I just want to agree on that.
Click it near to the 60% where it is written.
60%, sir.
Where it is written 60%, 67%, I think. On the next, there is a full screen button is there, sir. You just click it there.
Where, sir?
So you can just press F5.
1 minute.
You press function F5.
Just BS. Because it doesn't give you any.
Is it full screen only, sir, for me?
Order confirmation.
You full screen, sir?
Yeah, full screen only.
No, you are not. It's not full screen, sir. Sites also are visible. Sites are also visible.
Sir, top column where there is a home button,
Home button.
you come to the tab slideshow.
Okay.
Slideshow, sir.
Okay.
Sir, top left corner, if you can see the home icon.
Home.
Yeah.
There
So
is a-
in that there is a slideshow tab.
Slideshow.
On the
sir,
upper only upper only. sir.
Upper only slideshow, sir.
Same line,
No,
same line.
Upper.
Same line, sir. Say
Same line,
after
sir.
home there is insert,
Home,
then design. Yeah.
Yes,
Then,
yes.
sir, from beginning, slideshow. Sir, double click. From beginning.
From beginning.
Yeah.
from
From
beginning.
beginning.
Yes.
Double
Okay.
click, sir. Double click. Slide
Sir,
show,
you-
double click.
Double click, sir.
Slideshow double. From beginning.
On slide show, please.
Sir, this is Ronak here from
beginning,
support
sir.
team. I'm really very
Sir,
sorry
we
to
are-
interrupt in between. This is Ronak here from support team. I have
Yeah,
gained
Ronak,
the
can you
access.
help?
Just don't move your mouse, sir. I'll just put it into full screen mode.
Okay. Okay.
Ronak, can you do it from your side?
Yes, sir. I'm trying to do that itself, but I guess our system is working slow. I've already put it into full screen mode, but it is not taking the effect on the screen.
Okay.
Just give me
Sir,
one
don't worry,
second.
continue.
Just give me 1 second, please, sir.
Sir, you can continue with this. No problem.
No problem, sir.
Yeah, you can continue, sir.
Thank you very much, sir. First of all, I would like to thank Sudhir Shah, sir, for giving this opportunity for Andhra Medical College. Sir is, as you know, all of you know, Padma Shri Award in 2016. We're all proud of you, sir. And BC Roy Award in 2018. And sir got FRCP in 2022, the Royal College of Physicians. And we are very fond of your book, sir, Neurology and Meditation. Thank you very much, sir, for giving this opportunity. And sir is the founder of TISA, which we regularly attend. Next, I would like to thank my heart to Lakshmi Narasimhan, sir. Sir has got Best Teacher Award again in 2010 and prestigious President Award for Baker Award from AAN. And sir is executive member for World Federation of Neurology. And sir, you know how sir conducts Shine for the last 7-8 editions. We all like you very much, sir. And sir is very good devotee of Lord. So actually, why we have presented this? First of all, I would like to thank our senior Dr. Josna presenting in an excellent way. After that, Dr. Shushma, assistant professor, and Dr. Satish, associate professor, for dealing the case. So I will not take much time. Basically, why we have presented. So when I was an associate professor way back in 2011, first we started seeing these patients when Dr. Buchraju sir is the professor HOD. Then actually we presented initially 12 cases. Actually, my wife only, Dr. Bhagya presented in our AP state conference, then IAN. And since then, we have been collecting all the cases. Just now, when sir asked me to present a good case, just 4 days back, I was thinking what case to present. Then sir said, any interesting rare case. Then right now, in our ward, we have 2 cases of Wilson's disease with K-Fring positive. I thought, I think it is a better case because we have already 40 cases. With these 2, we have 40 cases. All 36 cases we have published already. And in the last 1 year, we have another 4 cases. I think it is better to share our experience of Wilson's disease with you, all of you. That's why, as Dr. Satish said, so Wilson's disease, so there are some atypical features in this case, which we like to discuss. So Wilson's basically is a potentially treatable genetic disease. Most of the genetic disease, no treatment. Now we are getting some treatment. It is a potentially treatable genetic disease. The treatment choice is liver transplantation. Most common than what previously thought. And every center, they must be seeing more number of cases. And they all autosomal recessive. And one more important point as for the diagnosis, though it is ATP7B, different diagnosis, there are a lot of mutations about ATP7B, more than 300 mutations. Now you can diagnose Wilson's even without those mutations, just all these children, and we are skipping all this because of lack of time. So basically, we have seen this modified Leipzig criteria. for the diagnosis of Wilson's disease. Very simple. Somebody come with a movement disorder like chorea or erythrosis with neuropsychiatric features with KF ring, there is enough to diagnose Wilson's disease in the setting of, because Wilson's can present to any specialty. Usually they come to a neurologist for unexplained ataxia, unexplained movement disorder, or unexplained chorea, erythrosis, or a movement disorder, unexplained femoral tract phenomenon, unexplained neurocognitive impairment, or they can go to psychosis, unexplained psychosis, a nephrologist for renal tubular erythrosis, like a gastroenterologist for unexplained jaundice, are asymptomatic to any fatal cirrhosis of liver or rarely hepatocellular carcinoma. They can go to ophthalmologist for loss of vision or sunflower cataract. They can detect KF ring. You can go to a cardiologist for arrhythmias. They can go to physician for anemia. They can go for a gynecologist for unexplained infertility. So any unexplained things, one should suspect Wilson's disease. So very easy to diagnose with this modified Lipzig criteria, which I'll discuss already. So the four or more, the diagnosis is established. This is previously what we follow, the previous Lipzig, now it is modified. So we have 40 cases in the last 10 years. So we analyzed relevant ST, clinical features, the KF ring and ceruloplasmin, and whenever necessary, 24 urinary copper. And all we have done all other tests, including MRI brain. So total there, you have 40 patients. Of these, 23 are female. In most of the studies, there is male preponderance, but we have female preponderance in our study. Let's say KF ring is present in 90%. In Wilson's, all patients get KF ring. In those patients who are hepatic cirrhosis, 5 to 6 patients, they have the KF ring is not present. The low serum ceruloplasmin is in 87.5%. Ceruloplasmin can be low, it can be normal, sometimes it can be increased. So abnormal, the 24-hour copper excretion is in 82.5%. MRI abnormals are only 90%. Only 10% we have seen normal MRI, especially in those hepatic form. Just to compare with other data from other Indian studies, you can see Dastur, Singh, and Rajmani, and Murthy et al., Pandit et al., and Singh and David Talisser. Most of the features more or less in parallel with those other studies. You see, usually they present dyskinesias, BIOPD, and 8% ataxia and mix. So some of our patients, they usually present with dystonia 27 of these 40, and speech abnormality 24, dysphagia 15, drooling of saliva 24, a classical Wilsonian face is seen in 25, and all we have done all KF ring, hemogram, LFT. KF ring is in 90%. All patients of Neuro-Wilson's we have KF ring. So MRI abnormalities are seen in 90%, starting from non-specific hypertonic signals in T2-8 images, the basal ganglia, thalamus, and brainstem lesions. So just to review the literature.
Dr. Gopi, sorry to interrupt. Your slides are not moving. Is it possible for you to try once more?
So no, not moving, sir.
No, you are on first slide still on the screen.
This slide, sir?
No, actually.
This slide, sir?
No, none of them are coming. Probably.
Sir, you stop share and then again reshare your slides.
You stop sharing and then again reshare it.
Okay, sir.
Yes, that's correct. Perfect. This is full screen and wonderful.
Okay, sir.
Can you go to the first slide, please?
Okay, sir. I'm going, sir.
Yes, that's fine.
Okay, sir.
Yes, that's perfect.
So we have 40 cases of total. So from 2013 to 2022, we have seen 40 cases of Wilson's disease in Andhra Medical College, Visakhapatnam. So basically, we followed this Lipzig criteria to diagnose Wilson's disease. It needs only the neurological symptoms and KF ring. So we analyzed these 40 patients with relevant history, KF ring, celloplasmin, and MRI brain, sir. So after the 40 patients we have seen, in 90% we have KF ring, and those who are hepatic from the KF ring is absent. All neurovelsons, the KF ring is present, and the low serum celloplasmin 87.5%, abnormal corpuscles in 82.5%, MRI abnormal 90%. In those hepatic form, most of these MRI is normal, and we can compare with all other studies from Hyderabad, Pondicherry, Mumbai, Pune, and Ranchi, and New Delhi and Bangalore. So most of the features are similar. Most of these patients are present with dyskinesias, young onset Parkinson's disease, ataxia, and mixed features. So 27 patients present with dystonia, 24 speech abnormality, 15 dysphagia, and 24 drooling of saliva, and 25 vacuous smile, and 15% they have cognitive impairment. And tremor is seen in 18%, ataxia 8 patients. So we have seen KF ring in 90% of the cases, and LFT is abnormal 17.5%, especially those who are in hepatic form. So MRI brain, we have seen all patients, we have taken MRI brain, and it was abnormal in 90% of the patient, and start from non-specific T2 hypertension signals to effect of basal ganglia, thalamus, and brainstem. So these are some of the Indian studies. Someone study with 21 patients with Wilson's disease, where tremors, dystonia, dyskinesia, and speech abnormality are more common. This is the investigative profile where celloplasmin levels are decreased in coincidence with our study. And CT MRI findings almost same. That is basal ganglia, thalamus, and cardiac nucleus and brainstem are affected. So to conclude, Wilson's disease not so uncommon because we've seen 40 cases in the last 10 years, and early correct diagnosis can prevent devastating consequences as the disease is a treatable genetic disease. Any patient who, when we cannot explain, unexplained ataxia, unexplained movement disorder, unexplained spasticity, unexplained psychosis, so we should suspect Wilson's disease, especially in the setting of past history of jaundice, and high index of suspicion is required. Consider Wilson's disease in young patients with exceptional features, unexplained neuropsychiatric manifestations, and unexplained liver disease. Thank you very much, sir.
Thank you, Gopi.
Sir, thank you, sir.
Sir, in fact, I should congratulate the entire team, Dr. Jyotsna, Dr. Sushma, Dr. Satish, and Sipanna Gopi for an excellent overview, and hope all of you would understand it was an excellent revision of the Wilsonian features, the review of literature, and their own case series, which highlights what is common in our country. My sincere congratulations to the entire team. My sincere wishes to all of them, all the listeners, a wonderful, happy new year.
Thank you,
and
sir.
wishing them, wishing all of you a peaceful, healthy, prosperous new year. I'm also proud of Dr. Sushma. She's my student, and I'm very happy that she is doing so well.
So much, sir.
And especially the ways in which she has classified the ATPases as differentials of ATPases, differentials of Icterus, differentials of KF ring. It was fascinating to learn. Lot of new take-home points. Thank you so much for everything. Over to Professor Sudhir.
Thank you, sir.
I think it was a most optimum, adequate discussion regarding Wilson, and most of the clinical features as well as investigations and appropriate therapy lines have been drawn very nicely. I think it is one of the very educative seminars, and we thank the whole team. Now, I have one question, Dr. Gopi.
Sir.
Did you get liver transplant in any of your cases?
No, sir. No, sir. Yeah. Actually, the treatment choice is liver transplantation, but because of various other reasons, we could not send it, sir.
No, that's right. Cost constraint is another factor. Yes. I do agree. But I mean, what is the latest recommendation? Whether it should be done early on, or we should wait till decompensated liver failure occurs?
Early on, sir. As early as possible.
Because Dr. Satish Kumar had mentioned that liver failure, acute liver failure and decompensated liver disease becomes the a true indication. I feel, and I saw some of the literature where they say that early on is better, but I couldn't find any series of patients who have been studied on that line. So, Dr. Lakshmi, are you aware of any such studies?
Sir, actually, as Gopi said, the earlier intervention is better, sir. But even if you have a very little neurological involvement, you should be prepared for worsening of the neurological manifestations post-transplant. And that post-transplant neurological Wilson is very difficult to manage, sir.
Yeah.
We may have to, in fact, the higher doses of D-penicillamine, I think Dr. Satish should have gone through what is your the post-transplant management of neurological Wilson?
So post-transplant, actually, the side effect profile of the D-penicillamine is aggravating, sir, when compared to pre-transplant. So side effect profile is the blood counts and other complications like nephrotic syndrome. These things are more problematic with the D-penicillamine therapy after the transplant period. Neurological symptoms regarding the only presenting as a pure neuro-Wilsons, liver transplantation in the early stages, I think doesn't give much deterioration, much progress, doesn't much progression of the disease afterwards also, sir. Few studies are there, sir, but most of the studies are with the liver failure only.
Yeah.
Most of the studies are with liver failure, sir, but only pure pure Wilson's, neuro-Wilson's presentations, only few studies like 4 to some around 10 to 17, sir. In that 50% of the patients had some improvement and 50% they have not shown improvement after the liver transplantation.
Sir, actually, in Wilson, sir,
yeah,
the very famous Wilsonian dinner, you know, all the neurologists in UK, they used to meet in the Gower Street in Wilson's house and discuss neurology at the dinner time. And I think today the Vaisak people have replicated the Wilsonian dinner in honor of Sir Kinyat Wilson, and I thought it's very appropriate for everybody.
Yeah. I have one more question. I mean, has there an exploration on gene editing or thing on those lines? Because there are a lot of mutations, as I read. And
so the Tata people have established the Kasper Krishnan, a laboratory in Chennai around 600 crores. The first disease which they are targeting right now is sickle cell anemia, sir.
Okay.
They are looking at all the single gene disease is what they are first targeting, and time is not far away where gene editing shall be available in our country, sir.
Oh, I see. Very interesting. But Wilson surely would be in the purview of that. Do you think so?
Yes, sir. Sooner or later it will be there, because it is they are in a business view. They look at the prevalence and then what are the number of beneficiaries there, so that the technique is used by a lot of people. That's how they look at that. That's why the sickle cell has a lot of incidents, especially in the Saurashtra belt here, in and around Madurai, and then the Kutch also there are a lot of cases. So the incidence is pretty high here. So that's why they have chosen that as a first. Sooner or later they will choose this also, sir.
But
you're right, sir. Your vision is right.
Yeah, to all my colleagues here, I mean, as a panelist, I think howsoever we are being taught and howsoever we teach our students, Wilson is one disease is still being missed often. Not let alone the physicians. Even I see neurologists also sometimes, it slips from their mind. So I think this is one disease which can have protein manifestations. It's a disease. Is a monster with many faces, so and it is treatable. So that's the most important lesson, and one should have a very high degree of vigilance for any extrapiramidal disorders. As they said, even chorea, acidosis, dystonia, tremor, and extrapiramidal Parkinson's syndrome or whatever. So that is one side, the psychosis, the liver disease, hematological conditions, bone marrow conditions. So this is one disease with many faces, and we should not miss because it is treatable. Unfortunately, I just diagnosed last week a case of Wilson who is 64 years, and I'm still surprised. I mean, he managed to live without it. It must be a minor variant, but so even late presentations of Wilson rarely are known. Dr. Gopi, what is the age of your patient who is?
So most of the patients in the second, third decade, sir. Almost all patients below 35, sir.
So I'm still surprised how is there something called acquired Wilson? I was wondering, but it satisfies all the criteria of Wilson.
The literature mentioned 5 to 85 years, sir.
So that is also patient has only tremor, spasticity, and KF ring is positive. And if you carefully examine, there is dystonia of the neck and little of the hand. So it's a focal dystonia again. Anyway, so there's a lot of lessons we learned today. Thank you very much.
So one small clinical point which I wanted to add, which Professor K is fond of. When you don't see any extrapyramidal syndrome, when you strongly suspect Wilson, you should make him walk around the chair.
Yeah.
Forwards and backward walking and walk around the chair will bring about the action dystonia in certain subtle cases of Wilson, sir. This he used to very frequently tell them moving around the chair, keep a chair around and then ask the patient to move around will bring out the dystonia. Sometimes the linear things may not bring around. And I don't know, these are all some certain subtle things which he used to stress. I don't know any of that. Yes, sir. Thank you, sir. I think you can manage.
Before we close, I would like to have one more opinion regarding this genetic testing. I don't think it should be reserved for certain typical situations like it doesn't satisfy these cases. I think we can use it little more frequently because it is the diagnostic test. It averts the biopsy and it is quick in the sense it doesn't take lots of processes for diagnosis. And I don't think it is very costly too. What is your take on this, Dr. Gopi, Dr. Lakshmi? What do you say?
I think the genetic test should be used more frequently. I agree with you.
Right.
And there are so many more than 300 mutations in ATP7B. So actually it is difficult to get, sir. In the literature it mentioned more than 300 mutations in ATP7B.
But
the whole exome sequencing can do that, sir.
So now
very costly.
Whole exome sequences is done by between 11 to 15,000 by certain companies.
Yes,
if you request. So maybe I think we need to churn a little more on exact application of gene studies in Wilson.
Yes, sir.
But in the coming times, it appears that genetic testing will be cheaper and it will be more desirable, easy, and the diagnostic dilemmas could be removed. Exome sequence is the only answer. You cannot do single gene testing. I understand that. Thank you, Dr. Lakshmi. You please wind up, and thanks to everybody for a nice presentation and a wonderful listening from all the participants.
Thank you. Thanks everybody. And I hand over to Professor Arun Siddha to wind up. Thank you.
Thank you, sir. And today it's really a great day as we are on the New Year Eve. Since tomorrow is the last day of year 2022, and we are all ready to celebrate and to welcome the start of New Year 2023 with lot of hopes and good wishes. And we are at the end of 30th session of Secret of Neurology, which is the longest web series of till date and it's the last session of the year 2022. Secret of Neurology is the longest web series. I, Arun Chadha, Associate Vice President, on behalf of Intas Pharmaceutical, would like to propose a hearty vote of thanks to all the honorable delegates who blessed us with their presence in the last continuously 30 months. And it's audience like you that makes the presentation awesome. Thank you very much for your unwavering attention throughout these presentations. And I would like to thank our honorable course director, Dr. Sudhir Shah sir, Dr. Lakshmi Narasimhan sir, for designing such a fantastic web series on neurology, which will be very helpful to all the DM and DNB students. We are very thankful to the young neurologist, Dr. Jyotsna, for presenting the excellent and unique case. Further to this, I would like to thank Dr. Sushma ma'am for presenting the differential case investigation and clinical features. And thanks to Dr. Satish Kumar sir for providing the investigation and management in such a great way. Further, I would like to thank Dr. Gopi sir, Professor and Head of the Department of Neurology, Andhra Medical College, Visakhapatnam, for sharing his experience in this case and providing the important learning point and proceeding of this unique case. The entire presentation will be extremely helpful and informative to all the participants. Once again, thank you for your gracious presence, and it's being clear with being with all of you today. Thank you for your patience, and I wish you all in advance a very happy New Year 2023. May the New Year will bring a lot of happiness, health, and wealth to all of you. And in first month of the new year 2023, we will meet again on 27th January 23 with yet another most awaited, the next session of Secret of Neurology. Till then, stay safe, take care. And once again, Happy New Year to all of you. Thank you. Thank you very much, sir. Thank you.
Thank you, same to you.
Thank you, sir.
Thank you, sir. Happy New Year
Thank
all.
you. Happy New Year. Thank you.